Hello, this is on pulse oximetry. Pulse oximetry is the most commonly used technique to monitor oxygenation. It reflects the 98% of arterial oxygen content that is carried normally by hemoglobin. Pulse oximetry directly measures arterial hemoglobin oxygen saturation. This is by differentiating oxyhemoglobin from deoxyhemoglobin using their respective light absorption. Oxyhemoglobin absorbs light at wavelengths of 660 nanometer, whereas deoxyhemoglobin absorbs light at wavelengths of 940 nanometer. A pulsatile circulation is required to enable detection of oxygenated blood entering the capillary bed. Percentage of arterial oxyhemoglobin is reported as saturation of oxygen, whereas oxyhemoglobin saturation is measured by a pulse oximetry is reported as SpO2. Such precision is needed because the oxyhemoglobin saturation as measured by pulse oximetry might not always reflect the reality of arterial oxyhemoglobin level. Because it is important to be familiar with hemoglobin oxygen dissociation curve to estimate partial pressure of oxygen at a given oxyhemoglobin saturation. As you see the shape of the hemoglobin oxygen dissociation curve, change in partial pressure of oxygen above 70 mm of mercury are not readily identified by pulse oximetry. Pulse oximetry recognizes all types of hemoglobin as either oxyhemoglobin or deoxygenated hemoglobin. They provide inaccurate information in the presence of carboxyhemoglobin and methemoglobin. In the case of carbon monoxide poisoning, carboxyhemoglobin absorbs light in the same wavelengths as oxyhemoglobin, so this leads to overestimation of oxygen saturation, whereas in methemoglobin, it absorbs light in both oxygenated and deoxygenated wavelengths, which can cause either overestimation or underestimation of oxygen saturation. So in those cases, pulse oximetry is not accurate. When we see limitations of pulse oximetry shows slow detection of acute hypoxemia. It cannot measure ventilation or partial pressure of carbon dioxide. It does not estimate or does not measure partial pressure of oxygen. It's not ideal suited to detect severe hypoxemia and hyperoxemia, and also it might cause digital injury in the case of continuous follow-up, especially in premature babies. When we see source of error in pulse oximetry, it might be technical or clinical factor. Technical can be motion artifacts or improper probe placement and the ambient light, whereas clinical factors that cause source of error include hypoperfusion and abnormal hemoglobin, hypothermia, anemia, venous congestion, dark skin pigmentation, nail polish, and administration of certain vital days can cause error measurements of oxyhemoglobin by pulse oximetry. Despite these limitations, pulse oximetry is a non-invasive, easily applicable, and effective means of evaluating the percentage of oxyhemoglobin in most patients. Thank you for watching.